Very pleased to be here today to present SB 1264, which will provide MEDI-CAL coverage for hypertension medication management services provided by an advanced practice pharmacist. Hypertension control in the United States has hovered at approximately 50% over the past decade, despite the dangerous role hypertension plays in cardiovascular disease. In the first line of defense, the medications for hypertension are generic and inexpensive. The California Health Benefit Review Program stated in their recent study that the most prevalent condition among non-dual MEDI-CAL enrollees in 2016 was hypertension at 27%. The analysis also stated there is a preponderance of evidence from 5 studies that the receipt of comprehensive medication management is associated with greater reductions in blood pressure than that of usual care. This includes one study published this year in the New England Journal of Medicine demonstrating that pharmacists managing medications in Los Angeles barbershops for patrons with uncontrolled hypertension are nearly 6 times more effective than usual care at attaining blood pressure control. With hypertension being one of the major contributors to cardiovascular disease and thereby the greatest attributable risk for death worldwide, SB 1264 is needed to help bring down blood pressure and lower rates of deadly cardiovascular disease. SB 1264 will create more access to communities that currently do not have hypertension medication management readily available. Advanced practice pharmacists will be free to provide these services from local pharmacies, so patients don't have to travel to a hospital or a doctor's office as frequently for hypertension management, thus making this service easier to obtain and more readily available. Engaging pharmacists in the management of hypertension is crucial to achieving goals for uncontrolled patients. Colleagues, I would like to introduce Dr. Stephen Chen, Associate Dean for Clinical Affairs for the University of Southern California School of Pharmacy, and Dr. Ron Victor, Director of the Hypertension Center at Cedars-Sinai Hospital Burns and Allen Chair in Cardiology Research and Principal Investigator of the trial on Barber-based intervention for hypertension control in African American men, the study previously mentioned. SB 1264 has no votes, and I appreciate your consideration today. If I can introduce my witnesses. Thank you.
Hello, I'm Stephen Chen, just to clarify. I'm the Associate Dean for Clinical Affairs at the OSU School of Pharmacy. I've provided or directed comprehensive medication management services for the past 30 years, most recently transitioning from Beverly Hills to Skid Row. So with the health disparities we're talking about, I've seen firsthand. And as someone who trains pharmacists to do this kind of work in medication management, I just want to clarify 3 points. The first is this bill proposes that only doctoral level pharmacists with advanced training and expertise in hypertension management are allowed to provide these services and then be paid for them. The scope of practice currently in California state law already supports all of the services being described in this bill. As the law describes, medication management by pharmacists is not an independent service. It's a collaboration between patient, physician, pharmacist under a collaborative practice agreement or protocol that's authorized and signed by physicians, by medical groups, or the health system. Their constant communication is required by state law, so there's no fragmentation of care that occurs through this program. And I can say that with confidence because my third point is this practice of having qualified pharmacists manage medications for chronic diseases like hypertension has been in effect in California for 5 decades in the VA health system and in Kaiser. The difference is that this bill is proposing MEDI-CAL payment for these services to allow the services to be provided more widely, as Senator Stone has described, in public places like barbershops and pharmacies. We recently completed a 3-year grant from the Center for Medicare and Medicaid Innovation, enrolling 6,000 Latino MEDI-CAL patients. Hypertension was one of the top conditions, and we demonstrated that having pharmacists manage hypertension significantly improved control rates versus usual care. I'm going to turn this over to Dr. Ron Victor. We'll talk more about the importance and value of this bill. Just want to also clarify that Dr. Victor has written the book on hypertension. He is the author of the hypertension textbook that the medical world reads to learn about hypertension, and he authors the chapters that cardiologists read to learn about managing hypertension. Dr. Victor.
Thank you, Steve. So hypertension or high blood pressure causes half of all heart attacks and 3/4 of all strokes. We can't cure most cases of hypertension, but we can control most of them with really excellent medications. They're now generic and low cost. But in the real world, as Senator Stone pointed out, the majority of of folks affected with high blood pressure don't achieve a safe blood pressure level today. So what's the problem? Well, in part, doctors are so busy in getting pressure to see more and more patients that the time for the doctor-patient visit is way too short than we'd like. In addition, patients can push back and sometimes don't comply with all the medications as prescribed. There have been over 40 trials now published that provide overwhelming evidence that the best way to control hypertension in practice is with a pharmacist-physician team approach to hypertension management. Now, in my own study, which is recently published, doctorate-level pharmacists made house calls to African-American-owned barbershops. So there they met the patrons, they reconciled the medications, they measured blood pressure, they checked laboratory results right there in the barbershop, and they prescribed medications under collaborative practice agreement with each gentleman's own physician. And then within 24 hours, they sent progress notes to the supervising physician, who could override them if they wanted to, but the collaboration is almost all the time is really superb. Now, my study, as well as most of these other 40 studies, were funded by the federal government, the National Institutes of Health. So probably hundreds of millions of dollars in research dollars have been spent to provide this evidence. And in my opinion, this bill would be a huge step forward in making this happen in real practice. In closing, 1/3 of our trial participants were MEDI-CAL beneficiaries, and at 12 months, the pharmacist-led program had no effect on the frequency of doctor visits, so it wasn't as though we're taking business away from the doctors. There was 64% of the men in our trial at 6 months achieved safe blood pressures with blood pressures in the 120s over 70s, compared to 12% of men who referred back to their practicing doctors. So in closing, I think this bill would prevent needless heart attacks and strokes and save lives amongst the most vulnerable among us in our population. So thank you for your consideration.
Thank you very much. Others in support, just your name and organization, please.
Lorianne DiMartini with the California Society of Health System Pharmacists, sponsor and support.
Thank you.
Dan Dong as a pharmacist and also as president of the California Society of Health System Pharmacists.
Thank you.
Michael Cho with the Providence St. Joseph Health System in support.
Thank you.
David Gonzalez with America's Physician Groups, also in support. We actually support another bill authored by the chair, a little bit more comprehensive, but this is a good step forward.
Thank you.
Good afternoon, Shannon Smith Crowley on behalf of the California Chronic Care Coalition in support.
Thank you.
Michelle Rivas with the California Pharmacists Association in support.
Thank you. Is there anyone in opposition?
Mr. Chair, members, Tim Madden, representing the California chapter of the American College of Cardiology. We are opposed to SB 1264. Before I turn it over to my witness, Dr. Norman Lepore, cardiologist and former president of our organization, I just want to make a quick comment on a few of the remarks. The senator mentioned this bill only applies to advanced practice pharmacists, and that's actually not correct. The witnesses also mentioned that it only applies to a pharmacist with an advanced doctoral degree. That's also incorrect. So when you look at the bill, specifically on page 2, lines 30 through 35, the two code sections that it refers to are just for a pharmacist. So this could be a pharmacist who graduated from school and is now eligible to provide these services. In lines 36 through 38, it is specific to an advanced practice pharmacist. So the senator is correct, it does apply to them, but it is applicable to a broader group of pharmacists that do not have the advanced level of training and education that an advanced practice pharmacist does. So with that preset, I'd like to turn it over to Dr. Lepore to go into more details on some of our concerns. Thank you.
Thank you very much for the opportunity. Thanks. Thank you for the opportunity to, for a few moments, to present our views of the California chapter of the American College of Cardiology. My understanding is historically the purpose of this bill was really to provide improved access to medical care to those who are in need. I'm not an expert at the Englishese that these bills are written in. However, I really am hard-pressed to find really how this seems to be the case. There's no question that the excellent work presented by Dr. Victor really creates a closed-loop, efficient model within a closely watched clinical protocol, where there is continuous collaboration with physicians, there's continuous collaboration in terms of the movement of information, and I think that, however, is not necessarily how this program is going to run with this legislation. There really are no caveats with regards to education. Even furnishing travel medicine follows protocols, furnishing naloxone has particular protocols, administration of hormonal contraceptives in consultation with the American Congress of OBGYN, immunizations really follow protocols from the CDC. Yet, however, there really are no protocols, there's no certification, there's no training. And blood pressure is much more than a number. This is 250 pages of the guidelines from the American College of Cardiology and the American Heart Association. I'd like to pass this perhaps around to our legislators here. It really goes to show really the complexity with which hypertension can be effected. And my concern is that the treatment of hypertension under the proposed does not allow for the efficient collaboration, the movement of information from the pharmacy to my office. This patient is now going to be treated in a very disjointed way by the pharmacist, by the internist, by the cardiologist, unless there really is efforts to enhance the level of communication. And again, my concern is the lack of training, the lack of certification in terms of this process. Also, I'm a bit concerned, particularly if pharmacists are going to be working in their retail pharmacies. I'm concerned about the conflict of interest. Right now, we really have issues in terms of what I prescribe in terms of a medication and what the patient ultimately is prescribed. It's either done by virtue of deals that are made with the pharmacy or the PBM or what have you, but I'm already having issues, and patients are already very confused. They get my prescription for a medication, they leave with an alternative medicine. And I think the secondary issue or the tertiary issue relates to the reimbursement issues. Believe me, my practice is busy enough. I still make sure I take plenty good care of patients. Hypertension is a prevalent disease and one with which we need to take care of carefully. But I really don't see how the writing of this bill really leads to enhancement of care in terms of populations that are not well served, as well as the necessary training and certification, as well as the communication that's necessary that you did see in Dr. Victor's work, which actually could be a model for how we do this. But I feel that very strongly that this legislation does not follow that model. Thank you very much.
Thank you very much. Are there others in opposition?
Jody Hicks, representing the California Academy of Family Physicians. We are opposed unless amended, just asking for this to be limited to advanced practice pharmacists with training in hypertension. Thank you.
Thank you. Anyone else? Okay. Bring it back to the committee for questions or comments. Questions, comments? We have a motion by Mr. Thurmond. A second by 3 people. Ms. Burke is waving her hand frantically, so we'll give that to her. First of all, I want to thank you, Senator, for bringing the bill forward.
Thank you.
I believe in the goals of comprehensive medication management, which is to improve the outcomes for patients and reduce healthcare costs. In 2016, I carried AB 2084, which would have provided MEDI-CAL coverage for comprehensive medication management. I'll be supporting the bill today, but I believe it's actually too narrow. I believe, as it only applies to hypertension management, medication management, and its benefits to rural areas like my district is highly uncertain. I don't know how many people would benefit and how many community pharmacists would actually perform these services. As the bill is written, the provisions mostly apply to health facilities, which would hospitals and skilled nursing facilities, not federally qualified health centers, which is where 50% of my patients get their care. There needs to be continued discussion on the long-term vision for comprehensive medication management. I will support the bill today.
Thank you, Mr.
And-
Chairman. If I can also respectfully respond to the opposition.
Certainly.
Thank you. I
Please.
appreciate that, and I appreciate them stepping forward. The intent of this bill, and I'll have my witnesses confirm, is that the entry-level degree is a PharmD degree, a Doctor of Pharmacy degree, and it is required to get into an advanced practice program that is certified to have those qualifications. And you cannot participate in this program until you have been appropriately certified as an advanced practice pharmacist in this particular area. Now, this doesn't mean that pharmacists are going to be putting up a shingle and operating independently, as the opposition would lead you to believe. This is a collaboration. I call it the triad: the patient, the physician, and the pharmacist working together. It is not a mandate. This is a voluntary program. If physician groups don't want to participate in this, that they have that option not to participate. But I think that many physician groups will be encouraged to have this collaboration in the best interest of maintaining somebody with a healthy blood pressure. And when the medications are not working or they have side effects, the pharmacist will collaborate with the physician to come up with alternatives. It's not done in a vacuum. It's all done together. And I'd like my colleagues to elaborate if I may.
So our trial, Dr. Lepore, was done under the current scope of practice of clinical pharmacists. So everything that we followed was under California state pharmacy law. So this only applies to PharmDs that are doctorate level pharmacists. That's for sure. We had a collaborative practice agreement, which I sent you so you could see what it looked like. It's not unique, but instead of 175 pages, we boiled it down to one page with big font, with the key issue in treating hypertension, which we published online. And so it's not that difficult, and as long as it's a great collaboration, just as you point out, between the supervising physician and the pharmacist, things will work great. And we were very pleasantly surprised that the pharmacists in our case and the physicians were not under the same building. They weren't employed by the same people. And the physicians were extremely pleased with how it took workload off of them. And if we ever get to value-based treatment, where you have to get patients' blood pressures and cholesterols and A1Cs to goal, this will be a great boon to physicians. So I think the real winner is the patient, and the extra safety monitoring, the extra pair of eyes on this was all in the good for the patient, and it worked out great.
I would just this is not a conversation between the two of you. It's a conversation between you and us.
Yes, sir.
So and at this point, it's the discretion of the author. So the bill's been moved and seconded. So
Thank you. I respectfully ask for an aye vote.
thank you.
Thank you.
So we have a motion by Mr. Thurman, a second by Ms. Burke. The motion is due pass to appropriations. Madam Secretary, please call the roll.
Wood.
Aye.
Wood, aye. Mays. Mays, aye. Aguirre Curry. Aguirre Curry, aye. Bigelow. Bigelow not voting. Bonta. Aye. Bonta, aye. Burke. Aye. Burke, aye. Carrillo. Aye. Carrillo, aye. Flora. Flora, no. Limon. Aye. Limon, aye. McCarty. Aye. McCarty, aye. Nazarian.
Not voting. Absent.
Rodriguez. Santiago. Aye. Santiago, aye. Thurman. Aye. Thurman, aye. Waldron.
Thank you.
Waldron, aye.
Your bill has 11 votes. It's more than enough to get out of committee. We'll leave it open for others to add on.
Thank you, Mr. Chair, colleagues. Thank you for your consideration.
Thank you very much, Mr. Stone.